months and they wait for this continuing tradition 7 times. I mean, that's very impressive. And we hope it will keep on and on and on. And Ovid gave an excellent overview of prostate MRI. And I think that what we'll do now is we'll take a deeper look into some of the things she touched on, and we'll see some cases and some how we do it. Okay? So let's begin. So like Ovid mentioned priorly, is the main clinical indications of prostate MRI today are pretreatment staging, evaluation of patients with elevated PSA negative biopsies, active surveillance before or during active surveillance, and evaluation of suspected post-treatment recurrences. So we'll begin with the pretreatment staging, and really the most important question that we need to answer when we do pretreatment staging on patients with prostate cancer is, are we talking about stage 2 disease, in which the tumor is still confined to the prostate gland, or are we dealing with stage 3 disease, be it 3A, B, or C, or 4, where the tumor has extended beyond the prostate gland? And the reason is that if the tumor has extended beyond the prostate gland, then there is a very likely chance that surgeons may not want to do surgery, and therefore not all treatment options will be open for the patient, rather radiation therapy, hormonal therapy, and so on. And that's in more advanced extraprostatic disease. So this comes from data that we know in the literature regarding the outcomes of prostatectomy, and how much of a chance is there for recurrence following prostatectomy based on the stage of the disease initially. So when we look out at 10 years, if the patient had even focal extracapsular extension, there was 1/3 of the patients will recur 10 years out from treatment. Now, radical prostatectomy is major surgery with significant possibility of complications and morbidity, including sexual dysfunction and urinary leakage. And there's no surgeon out there in the world who's going to want to do surgery and then have the patient come back a few years out with recurrence. So even surgeons don't want to do, urologists don't want to do surgery on a patient who has clear, gross extracapsular extension in most cases. Now, it is changing recently. There are new concepts in treatment which say that if there's minimal extracapsular involvement or minimal capsular involvement, some of the urologists will still do surgery, and then based on the surgical margins will decide whether to add radiation, yes or no. So it's changing all the time, but we need to give the information to the urologist for them to decide whether surgery is an option. Now, another little statement here is that people tend to think that the only treatment for early prostate cancer is surgery. Now, I'm the daughter of a radiation therapist, so I have to say right here and right now, that even for early stage prostate cancer, radiation therapy has the same long-term outcomes as surgery. So really the difference is between a patient who has an option between radiation therapy or surgery, or a patient who does not have the option. And of course, when we go to established DC or seminal vesicle invasion, there's a 70% chance of recurrence. So if there's seminal vesicle invasion, surgery is definitely not an option. So, when we just started doing prostate MRI, and I've been doing prostate MRI before dynamic contrast enhanced imaging and before diffusion weighted imaging, when all we looked at was the T2 rated images. It was a very short 15 to 20 minute examination, and we did the best we could. But initially, patients were referred mostly from the urologists, and you can divide patients with prostate cancer into 3 groups clinically. So there's the low risk group, in which if they have a life expectancy of under 10 years or clinical stage T1, then you really don't need a prostate MRI. You can put the patient either on active surveillance or surgery or radiation therapy, whatever you choose, but the MRI in most cases, if you have a low Gleason and a very low PSA, a very low Gleason, between 2 and 5, then in most cases the MRI will not benefit you. On the other end are the patients with high clinical risk, which is Gleason between 8 to 10 and a very elevated PSA above 20. And in these patients, you will begin with metastatic disease workup because the chances of finding metastasis are higher in these patients. Of course, if this comes up positive with a bone scan or a CT, then you don't need the MRI because the patient is not going to get local or focal therapy. However, if you have a patient in a low-risk group who has a life expectancy of over 10 years, or clinical stage T2, or a patient in a high-risk group who has a negative metastatic workup, Then you can benefit from performing MRI for local staging to decide what type of local treatment is most appropriate. However, the largest group who are performing prostate MRIs are the intermediate risk group. This is actually also the largest group of patients diagnosed with prostate cancer, and this means that a Gleason of 6 or 7 with PSA lower than 20, or a relatively low PSA in lower Gleason grades as well. And in these cases, we know that clinical evaluation is just not good enough. A picture is worth 1,000 words. We can see things that the urologist did not suspect, which will change the treatment management. So here's an example of 3 lovely gentlemen, all diagnosed with prostate cancer. Gentleman number 1 has a PSA, all of them intermediate risk, low to intermediate risk. All of them have PSA, gentleman number 1 has PSA 7.3 with Gleason 7, 5.7 with Gleason 6, and 6.5 with 3.4. Clinically, they're all very similar. Clinically, they all have minimal disease on biopsy with 10% of one core or 15% of one core only. However, their MRIs show different things. In patient number 1, it was a normal prostate MRI study. So this actually gives the option of active surveillance if wanted by the patient. Patient number 2, can you see now? Patient number 2 has a mass, a low signal T2-weighted mass, a small cancer in the peripheral zone, which is not involving the capsule. And patient number 3, all with the same clinical status. Patient number 3 has a mass, a cancer, which is involved in the capsule. So clearly the treatment would be different for each one of them. And here's patient number 4, also in the intermediate risk group, okay, who had a positive biopsy on the right only, but has bilateral masses on MRI. So really, as we said before, what we're looking for on a prostate MRI for staging is extracapsular extension or seminal vesicle invasion. I'm sorry, I'm a little sick today. Okay, and as we can see here, this is a case showing us clear gross extracapsular extension, where the capsule comes around here, and we have all of this tumor outside of the mass, outside of the prostate. And here are 2 cases of seminal vesicle invasion, one with small seminal vesicle invasion, one with a very large tumor. These are patients who are not surgical candidates. Let's talk a little bit about elevated PSA with negative biopsies. Prostate biopsies are a sampling process. And in any sampling process, there's a chance of sampling error. Like if we look at this apple here, though they took 12 biopsies through the apple, they didn't hit the worm, or in this case, or the cancer, in the real case. So a prostate biopsy is not very accurate, and we know that from the literature, that there are 2nd rounds and 3rd rounds of prostate biopsies which detect cancers not detected during the 1st round. And this gets even worse because the larger the prostate gland, the higher the PSA. So the more suspicious the patient is going to be. But on the other hand, the less accurate the biopsy will be, because if you're taking the same 12 samples from a small prostate or from a large prostate, in the larger prostate you're getting a bigger sample error. So we use prostate MRI, endorectal coil prostate MRI, to help direct biopsies. And mostly what we're looking for in this subgroup of patients are masses that are hiding in unusual or uncommon locations, or masses that are hiding in areas that the routine needle does not sample. Now when we perform a transrectal ultrasound-guided biopsy, most of the samples are taken from the peripheral zone of the prostate gland, mostly in the lateral and posterior portions. The needle does not transfer through the whole prostate to the anterior portion. It does not reach the very superior elevated portions of the prostate gland, and most of the central gland is not covered by a routine prostate biopsy. So we're looking for central gland tumors, anterior masses, and superior masses that were missed on the biopsy. And we find them, not always, but often. Okay, so here's a case of a 71-year-old man with a PSA of 20 and 3 previous negative biopsies. He had a huge tumor in the central gland. It's an anterior tumor. If the biopsy sampled these areas here, they did not reach the tumor. And as we can see on multiparametric imaging, which is very, very important when we're looking for masses that were missed on biopsies, then we see that there's a homogeneous low signal intensity on T2. Now this is important to differentiate in the central gland from benign prostatic hyperplasia. Cancers in the central gland are usually very homogeneous, and they do not have a well-defined border. They sort of have an ill-defined border, homogeneous masses. And diffusion-weighted imaging, of course, diffusion is restricted. This is actually not DWI, it's ADC. Therefore, the restricted area is dark and not white. And on dynamic contrast imaging, it enhances. And like Oik mentioned, it is very important to get early enhancement pictures, because once you miss that moment when the tumor enhances and the prostate gland is enhancing around, you're not going to see the tumor on the background of the prostate gland, which also enhances. This patient, by the way, had a Gleason 9 prostate cancer, and it did have anterior ECE at surgery. So here's another example. This is just a small mass in the central gland, which is in the very superior portion of the gland, and was missed on biopsy 3 times. And this is a patient with an elevated PSA up to 10.8, not so high, not 20 like the prior one, but he had 3 negative biopsies. The last one was 1 year ago. And what we can appreciate here is in the anterior portion of the apex of the prostate, there's a large mass with anterior extracapsular extension. This was missed 3 times on biopsy. Now the apex of the prostate is another area which is very difficult to biopsy, clinically difficult to biopsy. And here's that same mass on a coronal image, on ADC map, and on contrast enhancement. So here's a 57-year-old patient with a rising PSA up to 8.6 with 3 negative biopsies. I'm just showing you a bunch of these to show what we're looking for and what we can find. So this one has a very small apical anterior mass, again on contrast-enhanced imaging, diffusion-weighted imaging, and T2-weighted imaging. Doesn't show up so well on the screen. Okay, 51-year-old patient with an elevated PSA raised from 4 to 17 in 5 years with 4 negative biopsies. That was in 2008 when we did his first prostate MRI, and I read it out as normal. But he continued to have a rising PSA, now rising to 26 with 2 additional negative biopsies. So this patient has already had 6 rounds of biopsies which were negative. And I don't know how well you can see it on the screen. This is 2008, this is 2012. There's a large mass here anteriorly, extending from side to side. Now the problem being that it's very symmetrical, and it's adjacent to the anterior fascia, the fibromuscular fascia in the anterior portion of the prostate. So when I initially read this in 2008, I just thought it was a thickened fascia anterior to the prostate gland. It's so symmetrical, it's so even on both sides. In 2012, the left part is becoming a little more bulky, becoming a little less symmetric, so I suspected. But also what we added in the meantime was dynamic contrast enhancement and diffusion-weighted imaging. And then you can see that on diffusion-weighted imaging, it's low on the ADC max, but also it enhances very clearly on the post-contrast image. And he had a Gleason 9 prostate cancer, which was treated with surgery. So he had